So I like where we're at. We're split between two options here, and that's usually how we want to be, right? We want to be split between two possible options. So the big key with this is to just know the medication. So albuterol is going to be a medication that's going to help with bronchoconstriction, and that's going to open up the airways. So if you understand what that medication does, that then helps you understand which of these conditions is going to be most beneficial for. What medication would make B correct? Because both of these medications are kind of doing similar actions, right? What medication type will help out with angina pectoris? Or what is angina pectoris in the first place?
That's chest pain, isn't it?
Correct. So that's chest pain. And that chest pain is being caused by what?
A blocked artery.
I was like, can you deduce that it's being caused by your airway? I don't know if you can deduce that it's being caused by shortness of breath.
What? Angina pectoris?
Yes.
So angina pectoris is going to be specific for cardiac origin, right? So it's always going to be cardiac when we're speaking about angina pectoris. And so it's chest pain, but we can, if it just says broadly chest pain, then that opens a whole world of diagnoses and possible conditions, right? Because it could be a rib fracture, whatever the case may be. So you're correct if it's chest pain, right? It could be from different reasons. But when we see angina pectoris, that's specifically going to be for cardiac origin. And that is, why will they have chest pain from cardiac issues?
Well, lack of oxygen being delivered to the muscle.
Yeah, and that muscle will be your heart. So because there is a period of ischemia, right? So where there's no blood flowing to the heart, you start to get chest pain. And the medication you're going to get is going to be one that's going to open up those vessels and it's going to help blood flow in there. So that's why I say it's a little bit similar, because in both scenarios, you're getting a medication that's going to open up something. So with exercise-induced asthma, it's going to open up the airway, whereas with angina pectoris, it's going to open up the blood vessels. Well, you know the medication, so that's what is going to help you with that option. So hopefully that gives you a better understanding of the two diagnoses, because then this could simply be changed to where it's asking for another medication, which will be, so nitroglycerin, right? Nitro is going to be, if they ask for nitro here, that will be a scenario where that will be correct. So we have on here some interventions. For the most part, you guys did well with this. So when we're looking at this question, it's a very simple question. There's not a whole lot that you can mark out off here. It's pretty straightforward. We're looking at restrictive lung diseases. And when we're looking at pulmonary disorders, we have our two categories, restrictive and obstructive. With restrictive, what's the problem with restrictive, just in general?
They can't get air in.
Exactly. So any restrictive disorder is trouble with getting air in, which is correlated with inspiration, right? And then with obstructive, the problem is going to be getting air out. So if we look at these really are obstructive. Option B, C, and D. Those are when you cough, when you're doing pursed lip breathing, when you're blowing out a candle, all of those are exhalation-based activities. Incentive spirometer is the only activity here that's really focusing on inspiration, which is why that's the best option. All right, next question. All right, so we're split here. Similar to last time, there were three options. Does anyone want to offer any suggestions on what we should go over? Is there anyone who got stuck on something?
I think that the tricky thing on this one was that pulmonary fibrosis makes you think of cystic fibrosis.
Yes, and that's very common, right? That's very common, and I think that's why people often get mixed up with those two, because of that fibrosis. But you can see those are two different diagnoses. One belongs in obstructive, the other belongs in restrictive, right? So which one will be restrictive?
Restrictive is going to be pulmonary fibrosis.
Correct. And then cystic fibrosis will be more of your obstructive, right? And if cystic fibrosis was on there, definitely that would have been another option. I don't think that will be a good question if that was on there with chronic bronchitis as well, because both of those will lead to mucus secretion. So the only one on here really is the chronic bronchitis. you're going to have inflammation of the bronchial airways and hypersecretion. So that's the hallmark of that condition, even though not all of these, even though chronic bronchitis, emphysema, and cystic fibrosis fall under the umbrella of obstructive disorders, they're going to have specific characteristics that define them from the other ones, even though they will all have that manifestation of poor expiration, right? And then emphysema, we don't really see, oh, no one put that, so good. And then interstitial lung disease is very similar to pulmonary fibrosis. Next question. All right, excellent. So the trick here is that you're going to have chronic response to hypoxia and then acute responses to hypoxia. So that's what you want to make sure you don't get mixed up. And it seems like all of you guys did very well. So acutely, you're going to have cyanosis, drop in SpO2. Those are going to be very sharp acute responses versus long-term when people have hypoxia for a long time, you're going to see clubbing, and that's where the fingers get rounder. And you'll see those in individuals who have respiratory diseases such as COPD, right? And then you're also going to see polycythemia, and that is more of a compensation because there's just not enough oxygen. So your blood is going to then, your body is going to create more red blood cells to try to compensate for that. So it's possible in the long term that you'll see polycythemia and then clubbing as well. But acutely, cyanosis or drop in SpO2. All right, so we'll go to the next one. All right, so we're split between A and D for this. Pulmonary function test, specifically with spirometry, I feel like is one area that a lot of people get confused. Is there anyone that's just not strong on that? Is that where you tripped up, or is there something else, or is it more of the diagnoses?
So I think that I only reasoned that it was the pulmonary fibrosis is because the residual volume doesn't really like. I think I thought about it as though like the restrictive versus the obstructive.
Mm-hmm.
And so the other three were listed as obstructive, and that was listed as restrictive. And residual volume really shouldn't change unless there's some sort of restriction that's happening in the lungs that's keeping the lungs from, like, that's progressive, that keeps the air from going in. So I don't know if that's a good way to think about it at all, but that's just the way I thought about it.
Yeah. So like I mentioned, right, we don't really need to know anything about the question. And this is one of those. So Michael brought up a great point here. If you look, all of these options, A, B, and C, are all obstructive. The outlier is D, which is a restrictive. So this is a process where you can just eliminate. Remember, we said if the options are saying the same information, essentially we can rule all of those out because the answer is going to be clearly different from the other ones. So this is a scenario where we could just go pulmonary fibrosis is restrictive. You can just do an educated guess on and take that one. But then when you're studying and going over this material, especially if you get it wrong, just to understand where you got the confusion. Why would we choose emphysema? This was the other favorable option. So thinking about why you chose emphysema and then trying to correct that. If it's just not understanding the diagnoses, well, that's something that you can then work on to improve. So we then have, as mentioned, all of these are obstructive. One is restrictive. So that's the big key there. And with residual volume, you're going to see an increase in obstructive disorders because we get the air trapping in the lungs, if you remember that. So for this question, we're split between two options, C and D. And which condition will be the most likely to cause an increase in total lung capacity? So this is what we were discussing last time, right? We're going to have our restrictive and obstructive. And when we talk about the pulmonary function test, specifically with spirometry, we're going to see different changes that occur that in general, we can say will happen for all restrictive diseases and all obstructive diseases. So for obstructive diseases, more than likely what we'll see is that increase in total lung capacity. So that is consistent with option D, which will be increase in cystic fibrosis. And Mike, do you see the logic here also? Can you see what you mentioned what you did for the last one? Do you see what it is also here?
I basically just kind of went off total lung capacity being the complete capacity of air that's going to be in the lungs. And cystic fibrosis is the only obstructive one. So then you're not able to get air out. So it's going to increase the amount of air that you have in your lungs.
Exactly. And you don't even need to go that far because this is very similar to the last question, being that all of these other options, A, B, and C, are restrictive disorders. So this is the only outlier. And you see how you can then use the same logic and reasoning from the last one that carries over when you see these type of questions where it's asking about these spirometry results. So total lung capacity, residual volume, inspiratory reserve, all of those type of spirometry results, they all follow that same reasoning between restrictive and obstructive. All right, so we'll go to the next one. All right, so this one we're split a lot more. So up to you guys. What do you guys think? Do you want to go? What information do you think will be useful for us to go over with this?
I think going over maybe a couple of the options that are available, because some of them I don't recognize, so I just kind of had to make some sort of educated guess. So I think that's probably where my lack of kind of knowledge of knowing what the answers are to the question.
Okay, so let me ask this question. Which of these do you know from the option? Michael.
So I literally I'm not really recognizing most of them, unfortunately. But deducing mechanical.
Which one do you know?
Well, mechanical percussors is just pretty forward, so I knew it wasn't that one, just because mechanical percussion. Inspiratory muscle trainer, that's not going to have anything to do with trying to prevent alveolar collapse. So I knew both of those weren't an option, at least in my brain. But the other two, I'm not really sure what the other, I just kind of got lost from there.
Okay, so you know what option B and D are. So I'll then describe A and C. And Kelly, you said you know what incentive spirometer is, and you lucked out because that's the only one you really need to know, right? So sometimes it might be great if it was another scenario where mechanical precursor would have been the better answer, then that would have helped. So let's start with our technique for just, emphasizing what this question is asking. So what would we underline, which would be what's this question asking? And then what else would we want to know? Because this will help us narrow it down also.
Which of the following breathing device is going to be effective in order to prevent alveolar collapse?
Exactly. So we want to know what breathing device will be the most effective. And it's saying the established goal. Well, what's the goal? Prevent alveolar collapse. So that is really what the question is asking. To prevent alveolar collapse, what would you want to do? Breathe in or breathe out?
Breathe in.
Breathe in. So now we're going to look at the options and say which of these interventions work on breathing in. So mechanical precursors, the name kind of tells you what it is, but if you don't know what it is, it's just the vibration vest, and it's going to help with secretions. So that's not really going to help with inspiration. That's not you breathing. How about inspiratory muscle trainer? Well, it has the word inspiration on there, so that's tempting. So I can see why someone might choose that because you're going to be breathing in to this device, and this device has resistance. And what it's doing is adding resistance that's going to strengthen your diaphragm. So it's helping with breathing in, but it's using resistance. So let's see if there's a better option. How about flutter valve? Flutter valve, you're going to blow into it. You're going to breathe into the flutter valve, and it's that machine, a device that oscillates, it vibrates, and it's going to shake up the air in your lungs and help out with the mucus secretion. So not really a good option. B and C are kind of similar. And then incentive spirometer is the device people get after surgery, and they're just taking deep breaths in and then breathing out outside of the device. So that's going to be your best option because the purpose of that is to increase maximal inspiration, to fill the airway. Now, if we are discussing a situation where there's weakness in the muscles and we want to strengthen that, well, then D becomes your better option. So if simply all we're trying to do is aerate or fill the lungs with air, you want to just do deep breathing exercises, right? Or use an incentive spirometer. All right. If you have questions, let me know. If not, we're going to the next one. Okay. So we're split here for this one. So it looks like we just need to work on some of those interventions, right? On the study guide, if you look at the bottom, we talked about all of the different interventions that you can do. So let me go ahead and pull that up. So that'll be helpful for you to go over if you're not getting these ones correct. So that is down here. So those are the interventions that we can do, and we see all of these here. And we have specific interventions that we will do for airway clearance, and there's a list of those. There's multiple. But we can do process of elimination here. You're not going to miss this question because you don't understand the question, because it's pretty straightforward. It's going to be understanding the options here. So paced breathing, if we know what that is, that doesn't really make sense. There's no really strong competing answers for this one. Does anyone want me to go over that?
Could you just go over what the active breathing cycle or the active cycle breathing technique is? Like, what is just the definition of that?
Okay, so sorry, I clicked next. So let's do this next one and I'll explain that. Okay, so let's go back to the previous question. So active cycle breathing, does anyone remember this? This is one that usually gets skipped over or talked about pretty quickly, so it's okay. With active cycle breathing, it's an airway clearance technique, and you're going to be sitting down, and it's going to go through different processes of breathing. The first one is quiet breathing. There's like 3 phases, and you're breathing in quietly, and then you're going to start taking deeper breaths, and you're going to pause and hold those breaths. And you're going to do that repeatedly. And what you're going to do is by controlling how you're breathing and with air flowing through the lungs, it's going to help mobilize and loosen up the mucus. And after you do a few rounds of those, you're going to then cough. You do that a few times and clear out the mucus. Does that sound familiar?
Yeah, it sounds vaguely familiar, but it does. Yeah, probably
Yeah.
a while ago. But yeah.
Yeah. So you're just going through a few cycles of, controlled breathing, and that's helping move the mucus, and then you cough. And then for this one, once again, we're kind of split through these. So this is going to be some of our assessments, what we're listening to. And it's a pretty straightforward question here. And really, this one is hard because then you have to know what the sounds are associated with. So you have to get a little more specific with what you're studying instead of just doing a general information on, okay, these are the different sounds, right? So we have to then go into these different sounds and say, what is that associated with? When are we going to hear those? And with pulmonary edema, that's going to be fluid in the airways. So when the person breathes, you're going to hear these crackles, which sounds like if you take your hair and you just rub it in your ear, it's this popping sound, right? And the classical definition is discontinuous sounds. Go to the next one. Okay, so it seems like this one was pretty tough. We only got 2 correct for this one. So we need to understand what those characteristics will be for obstructive and restrictive disorders. We already talked about those differences with spirometry and the pulmonary function test, but also there are going to be other findings that you're going to see. Who remembers this phrase? I don't know if you guys said this, pink bloaters and pink puffers, blue bloaters and pink puffers, sorry. They don't really use that phrase as much anymore, but has anyone heard that?
I've never heard that. What was it?
Pink puffers and blue bloaters.
Nope.
Yeah, I've heard of that.
Yeah, so it's an old phrase that just describes what you'll see with someone who has emphysema versus someone who has chronic bronchitis. So with chronic bronchitis, they're going to be your blue bloaters because they're puffy, they have a lot of edema, and they're going to be blue from the cyanosis. And pink puffers is going to be because of that airway destruction with emphysema, and they're trying so hard to get air out. They're always in this position of tripoding, and they're always blowing to try to blow the air out because there's so much air trapped in the lungs from emphysema. And they don't usually get the desaturation and cyanosis similar to chronic bronchitis. And that's the thought process, why they use, it's a way to just remember pink puffers, blue bloaters. And people with emphysema, since they're working so hard to get air out, they become very thin, versus people with chronic bronchitis, they're bloated and they don't have that muscle wasting. Point being, there are different characteristics you're going to see with these different diagnoses. And one change you're going to see is on X-ray, because you have air trapping in the lungs, especially with emphysema, you're actually going to see this barrel chesting. Is that sounding familiar? Barrel chest? You should definitely have heard that.
Yeah,
Right,
that sounds
so-
more familiar.
So we get the barrel chesting, and that's because the lungs are just getting filled with air, and that whole chest cavity is widening. So on X-ray, what you're going to see anterior to posteriorly, it's going to be a widening, right? And that's that barreling of the chest that you're going to see. Next question. All right, excellent job. We're back on. All right. Was this one easy, or was it just a lucky guess?
Kind of a lucky guess a little bit, but I did some educated lucky guessing here.
Of course, that's good. And did you feel pretty confident with your guess?
Not initially, but then like after I clicked it and continued to look at the question or the other answers, then yes.
Do you mind elaborating kind of your thought process?
So resting heart rate of 100 beats per minute, that's elevated, but not necessarily, as far as I can recall, related to pulmonary embolism. A resting respiratory rate of 14 breaths per minute, that's just like a normal breathing rate. And I'm going to be honest, I don't remember partial pressures of oxygen or what they are or are not supposed to be, but I don't think, correct me if I'm wrong, but I don't think that necessarily matters in this situation. So,
Yeah, it could matter, but what we're seeing, you're exactly on the right track. Essentially, what we're seeing is normal values for all of these, right? So all of those options, they're all normal. So even if you don't know what you're supposed to see, and the tricky part is partial pressure, because once again, this is another area that just kind of gets rushed through, and people don't really understand it. So you might forget what the norm is, but essentially all three of those options, A, B, and D, it might be different for you, but A, B, and D are all normal values. 100 seems like it should be abnormal, but remember, our norm is from 60 to 100. If it's 60 or 100, it's still normal. At 101, that's when it becomes abnormal. So really, C is kind of our best option. If you just do process of elimination, now you know what signs and symptoms you will see with pulmonary embolisms. Next question. Okay, so here we're split again. So we're split between heart rate response, distance walked, and perceived exertion. So I think those are all good areas to be split, because when you learn about the 6-minute walk test, they probably taught you guys to check heart rate response and rate of perceived exertion also. Was that how you guys were taught?
Well, so I mean, just in the 6-minute walk test that I had seen done and performed by therapists, like I guess I got concerned, like I got mixed up with when it talks about their endurance level, like someone who can walk a distance with someone else who can walk that other distance, and someone else has more exertion than the other person, then their endurance is lower than if they had walked the same distance. So that's why I picked perceived exertion, because when it comes to like how much work they're doing and how much work they're putting in, therefore like has an effect on their endurance that they have.
Yeah.
I guess that's what got me caught up between the distance walked and the exertion perceived exertion.
Yeah, exactly. So that's not a bad option, right? Because when they're walking on this, if someone says, I'm tired after doing the flight of stairs, what would you say? That person has low endurance, right? Versus someone who's running 10 miles and they're barely breaking a sweat. You would be like, well, that person has good endurance. So perceived exertion can be tricky for this option. But really what we want to know when we are looking at some of these specific tests, right? Whether it's the 5 times sit-stand test, exercise tolerance test, all of those have specific objectives they're looking at. And with a 6-minute walk test, it's measuring the distance someone can walk in 6 minutes. So that is the objective. We do collect additional information also, heart rate response, perceived exertion. We'll collect some other stuff, but really what we're collecting, the information that the test is telling you is distance walked, and based on that, it tells us their endurance level. Next one. Okay, so we're split here. We have between emphysema, pulmonary fibrosis, and chronic bronchitis. So I have a question. Has this type of question come up already?
I don't remember seeing it or having anything like
So-
it. in the previous test.
Something similar, yeah, something similar was asked earlier about total lung capacity, and when we talking about restrictive versus obstructive.
Exactly. So that's what I want you guys to make sure you're paying attention to, right? As you go through these practice questions you're going to take, right? A lot of these will sometimes be saying the same information, just in different ways. So this is once again asking that question of restrictive versus obstructive and looking at the pulmonary function test. So I believe we've had at least two questions. One was the COPD, and then the other was restrictive. And we kind of talked about how with residual volume, you'll see that increase with obstructive. And total lung capacity, we also see that increase with obstructive diseases. So this is a little tricky here because really you should be split between B and D. And who knows why you should be split between B and D?
Those are both obstructive.
Exactly. So really those should be your two that you're trying to decide between. Emphysema, chronic bronchitis, they're both COPD. And we said in general, they're going to have similar presentations. Once again, this is where that whole pink puffers, blue bloaters, we don't really use that terminology anymore. But with emphysema, the big key here is you're going to have the ballooning of the alveoli, right? They get destroyed and you start seeing these airways just start increasing. And there's this air trapping that happens with emphysema. So they really get that expansion and increase in total lung capacity. With chronic bronchitis, the main key here is that the airways get inflamed, and then you're also going to have the hypersecretion of mucus. So if there was any information about coughing, productive coughing, that will cue you into chronic bronchitis. So it might ask for a obstructive disease. The question might be talking about obstructive, but those small cues about there's a lot of air in the lungs or there's a lot of coughing, or they might have issues with diabetes. All of those are going to be indications of what type of obstructive disorder it is. So if they say they have diabetes, what obstructive disorder might that be? And let me go over the obstructive disorders. We have emphysema, we have chronic bronchitis, we have cystic fibrosis, and we have asthma.
Emphysema is linked with diabetes.
No, so emphysema is going to be air being trapped, right? The alveolar destruction. When you think emphysema, just think air being trapped, airway destruction, alveolar destruction. It's going to be cystic fibrosis. Remember, that's hereditary. So if they say anything about genetic, hereditary, issues with fertility, diabetes, remember, it's not just happening in the lungs, it's happening throughout their whole system. So the pancreas and all these other organs have issues that you're not going to see with the other obstructive disorders because those other ones are just purely lungs. So when you see some mention of genetic, diabetes, or reproductive issues, cystic fibrosis, productive coughing, chronic bronchitis, right? Asthma, if they're talking about children, or if they get albuterol, remember that was one of our first questions we had. So those small hints are going to be what tell you which obstructive disorder it is. Okay. And long sounds is challenging, right? A lot of students have trouble with this one, so this is fine. And we're stuck between two options here, rails and wheezes. So we can do a process of elimination, but first we have to know what specific type of breath sound are we looking for here? What's the description from the question?
High constant pitch during exhalation.
So when you guys are now going to go back and review all of these, see the words that are being used to explain. So remember, I explained what crackles were. Those were discontinuous sounds, right? Sounds like hair being rubbed in your ear. So all of these will have their unique definitions, and sometimes they just put that definition into the question. So it'll be helpful to know what those are because it'll help you identify it when they ask those. If you recognize that, you'll be able to come to the answer And really, with wheezing, right? Just think about asthma. Anyone, if I was to ask any of you to make a wheezing sound, you would probably go, that's not very good. But, you know, it's just that type of high pitched kind of whining sound, right? So we've all heard what a wheeze sounds like. So,
I have a question on wheezes.
yes.
Can you explain the difference between wheezes and a stridor? Because I thought in some of the study material it said that wheezes changed pitch and a stridor stayed the same pitch. And I seem to see conflicting things sometimes on the difference between a wheeze and a stridor.
Yeah, so you might be able to get a little bit, and really even rhonchi sometimes might sound like it. The real difference between rhonchi is going to be more of like a snoring, and wheezes, they will say it's more on exhalation, but you can definitely hear it on inhalation also. But wheezes more with exhalation, and then stridor is going to be classified more because of upper airway obstruction, so someone choking. So that's more of the classical cue that it's a stridor, and it's going to be a little more aggressive and louder compared to a wheeze. Let's open it up for any questions. Is there any other topics that you want me to touch on again? We kind of did some reviews as we went along the way. We've talked about restrictive, obstructive disorders, what they are. We've talked about spirometry over the course of this. We've talked about assessments, the breathing.
I do have a quick question.
Mhm.
So with the question that was just on the presentation here about 95% patients' respiratory rate, I'm sorry, patients' OT level being at 95% at rest, and then doesn't the demand of oxygen increase when you start to do do exertion? So wouldn't there be an increase in the oxygen percent? Do you understand? Do you see
Okay.
what I'm?
I think so. You said it was one of the last questions.
It was one of the last few questions. I don't remember what number it was, but it was talking about a patient measuring at an O2 rate, O2 percentage at 95 at rest, and then
Okay.
it's that one there.
Yes.
Yeah,
Mhm.
the saturation.
Yeah, and you're saying as they start becoming more active, wouldn't you expect it to start increasing?
Yeah, so as they become more active, like from my understanding is that you get a higher, if they're lower, you will tend to see a higher percentage of oxygen saturation. And so why would you go all the way down to 90% if they're at rest, after no exertion whatsoever? Why would you wait until 90% and instead of just going back to what they were at rest?
So what you're saying is, in this scenario, why would 90 be the correct versus 95?
Correct, yes.
Okay. Does anyone else kind of want to try answering that question, maybe,
So
or give
my
insight?
understanding is that this is asking when you would stop, meaning like you're going to stop because the activity, they're not tolerating the treatment. And so you need to stop because it's not safe anymore. So if someone starts at 95%, that means that they already had a normal resting oxygen level. And so they should not drop to an abnormal, which is below 90. So if you have someone who usually has a normal oxygen rate and they drop to an abnormal, they're not tolerating the exercise and you should stop the exercise. That was my thinking on that one.
Mm-hmm. Yeah. What do you think of that, Michael?
No, I see. I guess I didn't fully understand the question. So you're
And
following
that's where I was
guidelines
going
and
to go back to. Yeah, and that's where I was going to go back to, right? So this is a scenario where you probably did not underline or fully get what the question was asking, because based on how you were explaining it to me, it's not that you were wrong where you were going and kind of what you were thinking, but it's not where the question wants you to go.
It's not what the question was asking, I think, because in my brain, like your oxygen percentage saturation is going to go up because your respiratory rate will go up That's just the normal adaptation that you have to exercise. That's the way the body adapts to exercise, is that you'll have a higher percentage of O2 saturation. So I think
I thought that oxygen tends to stay about the same or dip slightly, but blood pressure goes up a little bit when you're exercising. The systolic goes up, but I thought oxygen should stay about the same or slightly drop because you're using the oxygen.
Mhm.
So I don't think I should
Yeah.
drop that much, though.
Sorry, I missed what the last person said.
I was just saying, like, I was thinking the same thing. It should drop a little bit, but not 5%. That's a lot.
Mm-hmm. Yeah, so here's the big key for this question, right? And this is why those steps are important, because we want to make sure we just understand what the question is asking. It almost doesn't really even matter where they started, whether they started 98, 92, it almost doesn't really matter, because if they start exercising, what this question is saying, what is a guideline for when you should terminate exercise? So the ACSM has the guidelines for when to stop. It also says for systolic blood pressure, diastolic blood pressure, heart rate. So it gives those parameters for when exercise needs to be stopped. Is that sounding familiar?
Yeah, that does. And so when you say it like that, like, looking at the saturation percentage, like when you determine when you need to stop, I would have just picked the 90%. But when you're looking at the question, and yeah, I just don't think I understood the question correctly.
Yeah. So that guideline is essentially what you want to use, because let's take this over to heart rate, for example. And actually, I believe, Linda, you mentioned blood pressure, but let's go with heart rate. It's a little bit easier because there's only one number there. With heart rate, what do we expect heart rate to do with exercise?
Increase. Heart rate's going to increase.
Increase. Right. So if they're asked, this question could ask, this person had a resting heart rate of, pick your number, obviously safe to exercise, right? We pick our number, let's say 80. And then which of the following guidelines would be the most appropriate to determine when to stop? So when the heart rate drops more than 10, up to 20%, that's usually an indication to stop the exercise. So if there was an option that says when it drops to, I said 80, right? 70, that will be your answer, regardless of wherever they started. It's if they drop 10 below that. With SpO2, it's 90%. 90% is our target. That's the magic number. If it ever drops below that, we stop.
Yeah, no, that makes sense. I think
okay.
Linda has another question, I think.
Yeah, go ahead.
Yeah, the question, can you go over the question about the different lobes and which one would need to be cleared if they had hypertension and diabetes, I think it said.
Yeah.
It was the second to
Let's
last
see.
question.
Oh, I already passed it. No, that one's GERD. So we had two for postural drainage.
Yeah, one of them had some pathologies, and which lobe would you need
So
to
that's
work
this one
on
right
based
here.
on those pathologies? Yeah.
Yeah. So what would you like to go over?
I basically just had to guess on that one. I don't know how those pathologies impact which lobe of the lung is struggling.
Yeah. So do you
So
know
I think-
which?
Sorry,
ahead,
Linda,
Michael.
I think it's asking to modify the procedure due to the patient's hypertension.
Okay. So I guess
again,
I didn't read the question correctly. But I still just had a lucky guess either way. But
Yeah.
still don't know why the certain, I guess because I'm not great on the positions for this, but maybe we can go over why that position would need to be modified.
Yeah, and that's what I was going to ask. How comfortable are you with those different positions, right? Michael, do you have kind of any insight to help us with this one?
Well, I know that so it's really funny because I just had this with positioning in general with hypertension with a completely different question, but it was talking about Trendelenburg or Fowler's or anyway. But I just kind of know like the upper lobe is like you have to be careful when I think that I just kind of went through and just kind of acknowledged like you have to be careful with someone who has hypertension.
Hmm.
and just kind of know the different positions that may potentially increase someone's blood pressure. So
Exactly. So that's
laying someone down increases their blood pressure, and then the posterior, the lower lobe, they're at an incline. The table's at an incline, and it puts their head down in a downward angle, which then increases their blood pressure more.
exactly. So we need to know all of these positions. And I like to just group things together personally. So when we're talking about the apical lobes, it's at the top. And the lungs, right? If we think of the lungs, sorry. So can you guys see my screen here?
Yeah, we can.
The bottom. Okay. So if we have the lungs, we're just sitting here. This is your head up here. So we have the different parts of the lungs. And essentially, just think about, okay, well, if we have this top here, how would we drain that? Well, we will kind of want to move in a way that positions that part to drain. And you're having all of these different parts of the lung, right? You have essentially your bronchi and bronchioles, and all of that's going here. And when you move the lungs in different areas, it points it with gravity. So when we have the apical segments, if you can see, the person is always upright because in that position, we can get that downward pull of gravity. When we have the anterior segment of the lung, the person is usually going to be laying supine because when they're laying supine, gravity is then going to be letting that anterior portion drain. And then when we have the sides, which will be middle lobe or the lingular section, you can see that they're usually on the side, once again, letting gravity act on that. And then when we have the lower lobes, we kind of want to tilt the person upside down, right? And to get those posterior segments. So that's a nice way to just kind of group the different lobes and how they're positioned. Because then if we go to this question, it's asking for this position for this person who has hypertension. And that's the big one, hypertension here. So we know what those positions will be. And the big key here is if we put someone in that position with their head down, that is a contraindication, right? We don't really position people like that who have hypertension because it'll affect their blood pressure. So the only position that puts them into that segment, into that position there, is the posterior segment. Apical, they're going to be upright. Anterior segment, they're going to be supine, right? We want to drain the front part. And then superior segment, also, they're going to be kind of upright. So superior up here, they're going to be upright. So finding some way to think about how those segments, you can group those segments and make it a little bit easier to remember. And the way I just explained it there is kind of how it makes sense intuitively for me that, okay, this segments are here, so I'm kind of upright. The lower segments, I kind of want to tilt myself back, right? And drain those segments. So once you find that and then understanding hypertension, positioning them in that position will not be good. That's how you get your answer. Okay.